Hello, welcome to our webinar on safe care in your practice. I'm Lisa Harrod-Rothwell.
And I'm Elliot Singer.
And we're from London-wide LMCs. London-wide LMCs is the organisation that's here to support practices and staff who work in them across 27 of London's boroughs. We also provide advice, guidance and expertise to each of the local medical committees within those boroughs. Local medical committees are here to represent you in discussions with ICSs and other organisations that make decisions that impact on your practice and your working day. Anyone can stand to be a representative for one of our local medical committees.
We have developed this webinar to help you and your practice think about how you provide safe care without breaching any of your contract regulations or breaking any other rules. This is to think about keeping your patients, your staff and yourself safe while providing the care, and we have developed this alongside other resources that are available to you.
Elliot, you're a very experienced GP and a trainer. It would be very easy to assume that you're always in control, you always feel able to deliver safe, high quality care. Is that the case?
I'd love that to be true, Lisa. Sadly, it's not. I'll give you an example of a recent Friday experience I had. So on Fridays afternoon, I'm always duty doctor, and that's at the end of a busy week where I'm often feeling tired and fatigued. So recently I got a call from reception saying that we had the mum of one of our patients on the phone. She's well known to me and she is quite an anxious mum, and was given a history of a couple of weeks that he was passing urine more frequently and apparently had a sore mouth. We didn't have any appointments, and I just thought that can wait till Monday morning. It's late in the day, we haven't got appointments. Unfortunately, over the weekend, he actually went to A&E and was diagnosed with type 1 diabetes. He didn't have any complications as a result of it, but still it was an important diagnosis that I'd missed, and I really feel it was because I was fatigued, and that was the decision fatigue showing there. But Lisa, maybe that's just me. Is it?
It's definitely not. Certainly I've had lots of experiences, and I know our fellow GPs have had lots of experiences where we're trying to squeeze people in, where we have decision fatigue, where we haven't got time to give to our patients. And then there are other elements where we're operating with a huge amount of uncertainty and sometimes having to deal with elements that are outside of our expertise. So you and I are not alone. In fact, our workforce survey shows that less than 1/4 of all practices feel able to deliver safe care over the coming months. Most of those practices say that this is down to workload transfer from other providers, resulting in an increase in workload and also operating beyond the limits of their expertise. We're not failing, we are being failed. We know now that we are dealing with more and more patients, and our patients are more complex and they're consulting with us more frequently, and often they require services or greater expertise that we can't offer, and yet when they can't access that elsewhere, they come to us. And what's more, there are fewer GPs offering the care. We now have more patients per GP. So it's not you, it's not us. So we've just talked about safety, but I think we also need to talk about quality of care. Quite clearly, if we are squeezing more and more patients in, the quality of our care drops, and this has important implications. It has implications on our patients who experience a lower quality of care. It has implications on us as GPs and the staff working in our practice. Work becomes increasingly stressful. It has an impact on our mental and physical health and the well-being of our families. And what's more, when we're not able to deliver the quality of care that we trained for, that we know our patients need and what our patients expect, we experience considerable moral injury and distress. And this too is having a significant impact on our mental health. It also has a significant impact on our practices. So allyship between patients and their local surgery has always been very high, Patients value what we offer as GPs, and people value the place of our practice in their local communities. But as the quality of our care drops, that allyship drops, and that has important implications for the future of our practices. We are seeing a worrying impact, aren't we, on the sustainability of practices?
Sadly, we are, and we know that practices are closing down. And if we think about it, we've got limited or fewer GPs and practice nurses, and we've got a team of other healthcare professionals that need additional support and supervision. And in this environment, people want to do the right thing to provide safe care. So people tend to work harder and longer, and neither of those things are sustainable in the long term. So what tends to happen is people work longer, but it's not just the length of time, it's the intensity with which they work. And they do that because they want to provide safe, high quality care for their practice. The problem is that's not sustainable, and over time people start to burn out. And when that happens, their response is to either reduce their sessions down or to actually leave the practice as well. And what that does is it puts more pressure on the people that are still there. And over a period of time, those people start leaving as well. And patients start to be less satisfied with the service and put more complaints in. And that further burdens people and makes people unhappy in their role and causes people to leave. The impact on this is that you have difficulty recruiting, and nobody wants to join a struggling practice. And you then go round that cycle a few times until it comes to the point where either the partners feel that they can't maintain the practice and hand back their contracts. All too frequently we're seeing it's a result of either NHSE action or CQC action that results in the practice closing. And that's a huge loss to the local population.
So what we're saying is GPs and staff are working harder and harder and harder because they think that's in the best interest of their patients. But actually it's not, because it's impacting on the safety of the care we can offer, the quality of care we offer and how we meet need appropriately. It's having a negative impact on our staff, and ultimately it's threatening the sustainability of our practices. But realistically, what can we do about it?
So the BMA produced some really helpful guidance for this in 2018, Safe Working in General Practice, that has been updated. And this is where we get the idea of 25 appointments per day. And actually this was taken from European general practice recommendations. And now we have to think about that. It is supposed to be a maximum of 25 consultations per day. Now, there are exceptions to this and times where we may need to go above that, but equally if we're dealing with patients of a higher complexity, we may not be able to do that number of appointments per day. Now, there's always going to be exceptions where you do need to slightly go over that, but that should be exceptions and not the rule really. So we should be aiming towards making that the normality, that we're seeing a maximum of 25 per day. And actually, when you look at what's happened since 2004, when the current contract was introduced, we know that the number of times patients consult with us on average per year and the complexity of the problems that they are presenting with has increased. And so the point of capping these appointments is actually to enable us to spend more time with our patients so that we can provide them with the safe quality care that they need.
We frequently hear two myths that stop practices doing things differently, don't we?
We do, and that normally relates to people being worried that they will breach their national contracts, and also the patient satisfaction will go down and complaints will go up.
Shall we bust those myths? Shall we start with contractual breaches and requirements?
So the first one then, let's talk about 10-minute appointments. Let's be really straightforward here. Nothing in your GMS contract states that you need to offer 10-minute appointments. That is not a contractual obligation. Now, I understand that some of the local contracts do have details about the number of appointments you're due to be offering, but these are voluntary local contracts. And if the resourcing and if the service offers aren't deliverable, then we need to be thinking, should we be providing those? You're not obligated to provide these local contracts. The next thing why we're thinking about this is we're not an emergency service. And actually it's BMA policy that states that we're not an emergency service. Now in recent years there's too much that's been put into about the acute care needs. But we know from evidence that the greatest value we often add is about that relationship-based medicine and that long-term care for the patients. We've got finite capacity. So if we're putting so much resourcing into the acute care, we need to think about how we support these people with their longer term needs. And finally, the myth that we can't redirect patients. Actually, our contract says about the management of patients that includes referral onto other services. So Lisa, I hope this reassures you that we are safe to actually determine the length of the appointment and the number of appointments that we offer for our patients.
That's very reassuring. So in summary, practices can determine the length of their appointments, the number of appointments, and the distribution between planned care and acute care. But practices should engage with their patients if they want to do things differently, shouldn't they?
And that's important. As I said before, essential services in a manner in discussion with your patients. So you can make these changes, but the advice should be to engage with your patient representative groups so that you take them along and they understand and they help you shape how you're going to redesign your services.
So that's busted some myths about our contract and our requirements. Let's bust some myths about patient satisfaction.
So thinking about the myth that patient satisfaction will go down and complaints will go up. I mean, my own experience of this is that we introduced a cap at, it's actually 26 appointments per day, 13 a session a few years ago. And what we've noticed is there's been no increase in complaints and there's been no decrease in the patient satisfaction. But Lisa, is this just my experience?
Beds and Hearts LMC did a fantastic piece of work. They took the nationally published data about patient satisfaction and then they looked to see whether there are any correlating factors with other published information. So firstly, they looked at the correlation between patient satisfaction and the number of appointments per 1,000 patients offered. Surprisingly, they found no correlation. That means that there are some practices offering fewer than average appointments in terms of numbers with the highest satisfaction levels. And the other side of that is we also have practices who are offering an incredible number of appointments per 1,000 patients who have the lowest satisfaction levels. But interestingly, when we look at patient satisfaction against length of time with your GP, there's a clear correlation. And I suppose if we think about it, this is what we'd expect. We know that patients value time with their GP, they value being heard. And this is seeming to suggest, certainly looking at correlations, that patients may prefer quality over quantity.
So what you're saying really as a bottom line on this is that if we adopt these safe practices and cap in the appointments, that we won't get an increase in complaints. And actually, it's not going to be detrimental to our patient satisfaction, and possibly some evidence suggests that actually patient satisfaction would go up.
That's what the evidence seems to suggest at present, yes. So, Elliot, if practices want to make changes, how can practices take this forward?
Well, there are a number of resources. So we have the access guide that we developed working with HLP to get people to be able to look at how they can make changes to their access and appointment systems. Then in addition to that, we've got resources that we have to support you in assessing local contracts. This includes considering what resources are available in the workforce that you have. Remember, these are voluntary contracts, and if the resources aren't sufficient, a practice needs to think whether or not they're going to deliver it. But any changes you make, as I've said previously, you need to be working with your patient groups. So thinking about that, Lisa, is there any assistance we can give to working with your patients?
Absolutely. So we've been working with an organisation called Co-Create, who are experts in this field. We've produced a resource pack that has everything a practice needs to be able to engage effectively with their patients. It has a workshop plan, facilitators notes, template invites. It also has advice on follow-up and taking forward actions. We also at London-wide LMCs have a number of trained staff who are able to offer advice and guidance on any further questions or queries that practices may have regarding engaging with their patients about safe care. We've been talking about safe care in relation to a number of appointments, but it's important, isn't it, that we are able to use our finite time most effectively and in the best interests of our patients. We do lots of things, don't we, that we probably shouldn't be doing in general practice.
So we're frequently hearing about sort of the workload transfer from secondary care and frequent things that we're being asked to do that just feel inappropriate. And I think the problem is often GPs feel obligated to undertake this work. And I think a lot of the time we're not actually aware what is in the NHS contracts and what the hospital obligations are.
I think that might be another myth we have to bust here. So since 2017, hospitals have had requirements about interface working. I'm not going to go through them all in detail now, but that information is available. There are links and further information as part of this webinar pack. But to summarise, hospitals should not be expecting us to request investigations on their behalf. We shouldn't be chasing their results. We shouldn't be having to notify our patients about the results of hospital requested tests. If a hospital colleague recommends that a patient has a specific amount of time away from work, they should provide a fit note. And what's more, it should be for the entire duration that they recommend. If patients have queries about their hospital care, those queries should be directed to hospitals because they are the ones who can respond to them. And the way that patients do that should be communicated clearly.
So that's all well and good, and it sounds great in theory, but can you think of any examples recently that you just had ridiculous requests?
Unfortunately, there's quite a lot to choose from. I think probably most recently was somebody phoning me up for a sick note to cover their post-operative period from their hospital bed. How about you?
Yeah, I've definitely had that one, and the other one I thought was quite crazy recently was a patient that called up for an emergency telephone consultation. When I called her back, she was actually in A&E and at the time consulting with either the nurse or the doctor that was there. And she was asking me what they were telling her to check to see if the advice she was receiving was correct. It was absolutely ridiculous. The problem we've got, Lisa, is sometimes when you're busy, it's just easier to do it and then have a moan afterwards. It takes a lot of effort to sort of push back and write to the hospital or refuse to do something and explain that to the patient. Fortunately, both the BMA and us at London-wide has produced a number of resources to try and make that easier, a lot of template letters that practices can use. Because if we don't continue to challenge this, we're never going to change behaviour. And I honestly don't think that most hospital doctors know what they should be doing. And the only way to create the behavioural change is actually to keep reminding them and push back on this work. And while we're thinking about that, we've also got the issue about referral forms, haven't we?
Yes, so in principle, I'm not against referral forms. If there's a referral form that supports me to convey the information that I think is important to convey, that the recipient requires and it's implemented in the right way, that would be really time effective for me. But unfortunately, that's not all the case. All too often, and I know that my experiences are shared by others too, I can't find the right form, I can't find the right pathway. When I do find the form, it's really time consuming to complete. Sometimes it's asking for information I can't be expected to know. Occasionally the form is protected and I can't even put the information into it. And then you can get to the end of a form only to find some quite extensive exclusion criteria, but of course that's after you've completed it. And then having got over all of these barriers, you can then send it off only to receive a bounce back reply telling you you've used the wrong form and the pathway's changed. But of course, it's really rare that the right form is then attached to the message. All of this has impacts on patient care and on me as a GP. It delays referrals and I find it immensely frustrating. I tend to find that I am playing these games at the end of a very long day in my own time when I'm exhausted. Am I obliged to do this?
You'll be pleased to hear you're not. So if you think about your obligations, so you've got the GMC obligations in terms of referring appropriately and providing the right information. So that would include things like the history of presenting complaint, past medical history, drug history, allergies, etc. But that can be done in a referral letter. We do have under our GMS regulations, an obligation to use the ERS system where available. So you do have to use that, but you don't have to use the referral forms. The one caveat I'd put to that, of course, is for 2-week wait referrals, because we don't want to be missing any information or cause any delay. So those urgent referrals.
That's really helpful. It definitely is worthwhile reiterating the point that for 2-week waits, we should continue to use the forms.
So all of the resources we've talked about so far support practices to change things that are within their gift. But some of the things, like the referral forms, aren't within the gift of the practice to change. Yet they still cause frustration and waste our time.
Yes, if any member of the practice feels that they can't offer safe patient care because of a decision or a pathway across the system that's not within their gift to address, we really do want people to reach out to their LMC to let them know. This enables us to work with colleagues across the healthcare system to address these issues. And furthermore, if colleagues feel that there are things that are in place that are needlessly bureaucratic or cost them a lot of time so that they can't invest their finite time in the best ways for patient care, again, please do reach out to your local LMC so that we can help and try to address these issues. All of the contact details are available at the end of this webinar and on our website too.
Okay, thank you. And we couldn't talk about safety without, unfortunately, talking about the increase in violence and abuse towards practice staff and practices and clinical staff as well. And as a result of that, London-wide LMCs, following discussions with both Met Police and other experts, has produced our guidance on violent and abusive patients. Now, within this, it does outline ways of looking at your practice and trying to prevent incidents occurring, training you can provide for practice teams in how to de-escalate, and also how to deal not just during an incident, but how you support your staff and other service users after an incident. So again, that's available on the website, and it would be, in this day and age with all what's going on, unfortunately it is something that's needed, and I'd strongly advise practices to look at it. So that brings us towards the end of the webinar. Lisa, what would you like people to take away from this?
I think one of the key messages is that if you don't feel that you're able to always practice safely, that it's not you. I think it's important that we do discuss as practices how we can ensure safe patient care. Thank you for listening to our webinar. We really would encourage you to think about what you're taking away as individuals and what you're taking away as a practice. We'd like you to think about what are your next steps, by whom and by when, and also what support that you might need. I really do encourage you to have a look at this, our safety working pack. There are so many resources in there to help you. We've mentioned the access guide, the patient engagement resources, and there are template letters that help you politely push back on work that shouldn't be landing on your desk, with explanations to colleagues and other providers as to why. There's also lots of other advice, guidance and resources too. If there's anything else that you require would be helpful, please do let us know. Elliot, I, the London-wide team and your local medical committee are here to support you. Thank you for listening.